Good afternoon, and I would like to thank SAGES and the review committee for giving us the opportunity to present. And I'm here presenting on behalf of our study group at the University of Buffalo. We have a Center for Surgical Outcomes Research. We focus on bariatric surgery. We listed all the disclosures, and none of them are relevant to the study. In the current age, we use data to make all sorts of decisions in our personal and professional lives. We make decisions about patient treatment, about residents' competency, about evaluating quality of population outcomes, quality of hospitals, providers, calculate reimbursement, and develop quality improvement programs. A lot of data have been available and specifically allocated for those decisions. Many of you are familiar with these data sets: NISQIP, VAQIP, SEER, Medicare, various clinical registries, and disease-specific data sets. Recently, we have a new wonderful opportunity to work with National Bariatric Surgery Registry, and of course, a lot of us are interested in this data. So this data, in case you don't know, is a byproduct of a joint initiative between American College of Surgeons and American Society for Metabolic and Bariatric Surgery that united their accreditation programs in 2012 to develop a single set of recommendations and started tracking all accredited centers. And so this is a true registry. It's not a sample. All bariatric cases by participating centers get reported into this registry. And for public use in 2015, the college released a participant user data file that includes 30-day outcomes only. The advantages of MBSAQIP are well known. We have a very large national data set with thousands of patients. We have a lot of longitudinal data and various clinical and demographic information on the patients. The limitations are less understood and less reported. Out of the 29 research studies that have been published using this data set up to the February of this year, only 5 studies identify strategies that investigators use to assess quality of data or overcome limitation of the data. So we received the data set and we're very excited to start working with it and identify from time to time unusual and not explainable situations. So this particular patient, number 1, ballooned from 380 pounds to 367 kilograms right after the surgery. And this patient was successfully operated and then readmitted on the same day and then discharged from readmissions on the same day, which makes no sense. So we decided to further evaluate the quality of the data set for data completeness, accuracy, and consistency in order to develop a set of recommendations for future analysis for any interested investigators, specifically focusing on residents and quality improvement research. So we combine all 5 files that come with the registry in a single flat file and develop a set of tests and validity checks to examine consistency, accuracy, and completeness of the data. And for the purpose of this presentation, we specifically focus on 1 key outcome measure, BMI, 1 key provider quality indicator, such as reoperation, and 1 hospital quality indicator, such as readmission. So the tests were designed longitudinally and cross-sectionally and compared completeness and consistency, whether different variables that describe the same processes agree on the report, and identify the following interesting strategies. So out of the 168,000 patients who received bariatric surgery in 2015, a fair number reported either unknown or physiologically impossible BMI, and many reported missing data, which resulted in an overall data set of 142,000 completed observation, which means 20% of data were discarded. Out of that data, 7% of total observation were discarded because of inappropriate or unusable BMI data, which is the main outcome in the bariatric data set. So this diagram describes the BMI variable in the data set. As many of you know, insurance in the United States started reimbursing for bariatric procedures started at BMI 35 with multiple complications, or 40 if based on obesity only. The patients in the data set had BMI from 15 to 149 with a mean BMI of 44, and a fair number of patients had BMI of 30, which is not reimbursed but potentially possible if patients pay out of pocket. In terms of the weight loss, the amount of weight loss in the data set ranged from gaining 625 pounds to losing 522 pounds, which account to between 70 and 130% of a pre-operative weight. As I showed early, there's also inconsistency in the sequence of events. So there are patients who reported readmission before the day of discharge. A lot of patients were readmitted on the day of discharge or on the day from an index operation and discharge again from the readmission on the same day. Finally, we examined additional variables that MBSAQIP created based on clinical notes and the billing information available to individual centers. So there are two variables that describe whether reoperation or readmission was unplanned at the time of index procedure. And the two answers are possible. Response yes, meaning the readmission was unplanned. On response no, meaning it was not unplanned or logically planned. So 7% of readmissions and 12.5% of postoperative procedures were planned, which is not a problem. But if you look at the categories of planned procedures, those include vomiting, diarrhea, fistulas, anastomotic leaks, pneumonia, and many other indications that could not possibly be planned at the time of discharge. Same applies to postoperative procedure. So we concluded that our original excitement about the quality of MBSAQIP should be taken with caution because of some challenges with the quality of reported variables, data inconsistency, and a lack of clear definitions for the variables that provided in the registry. Based on our experience working with other large national and surgical data sets, we provided a set of recommendations that could be useful to centers if they're planning to work with NSQIP data, specifically if they're planning to use it for residency research or quality improvement. And those include utilizing advantages of health IT systems that could provide automatic data checks that you cannot move to inputting the next field if the value in the previous fields are out of normal physiologic range. That could be pre-set up. We can also provide data consistency audits, not based on the fact whether the data in the registry corresponds to the data in the medical notes, but based on the previously inputted values and multiple parameters. Also, the data auditors who provide the data input should be given specific recommendations to make the process of data abstraction more similar to between different EMR systems, because those fields may be populated very differently whether you use Cerner, Allscript, or Epic. And finally, we would like to propose to MBSAQIP to start educational programs, just like NSQIP is doing, and many of you are probably going to NSQIP conference in July, that will share the data challenges, educate researchers, hospital administrators, and surgeons about unique challenges of working with pre-existing data, because it originally was never designed for research, it was designed for clinical practice. And by doing that, hopefully we can improve implications of the research we conduct using pre-existing data sets. Thank you very much. I'm happy to take any questions.